Dear colleagues, my name is Yong-Dae Kwon, coming from Department of Oral and Maxillofacial Surgery, Kyunghee University, Seoul, Korea. Today, I'm going to talk about sinus floor elevation and the choice of approach. It's really clear to do lateral window in a case with 2 mm of residual bony height, but we have some gray area where the residual bony height ranges from 4 to 6 mm. In this range, you can do both of the approaches. So both approaches are available. For the decision making, other clinical factors besides this residual bony height, like clinician training background and the missing location, should be considered as well. For example, this is a single molar replacement case with a 4 mm of residual bone. In my hand, lateral window was comfortable, but you can also have a chance for transcrestal approach as well. So according to these CBC scan images, I planned on a placement of 10 millimeter length standard diameter implant combined with some sinus graft. So sinus floor was elevated from the anterior wall and a tissue level implant was placed at the same time in this patient. With this approach, we can have a direct vision of the surgical field. I think the one of the most good advantage of this technique is you can hold the surgical field uh, in your hand. You can control things happening, and any intraoperative complication can be witnessed. So if something wrong, you can go and handle it. Besides the clinician's training background, choosing one approach, patient discomfort often deters the choice of lateral window. So we usually talk about patient discomfort and post-operative complication when we go for a lateral window technique. From the patient point of view, there was a study investigating how the patient liked the surgery. They were asked how they liked the surgery at the 14th post-operative day. From this study published in 2018, although a handful of people went through kind of unpleasant experience, the level of patient discomfort was the same between the two surgeries. So patient discomfort would not be a determinant for the choice of approach. So there is no significant difference between the two approach to the maxillary sinus. Moving on the outcome, looking out for some literatures, the overall success of implant placed via a transgressor approach reached almost 93%, which is almost the same rate with those placed in pristine posterior maxillary region. So it shows really high level of success, even you do some kind of a transgressor approach. And considering some clinical modifiers like residual bony height, the survival rate may vary. If the residual bony height is no more than 4 millimeters, like this table, then the survival rate would go down to around 86%. Especially a 6 millimeter implant showed quite disappointing outcome, which is less than 50%. Putting things together, the outcome would be the most predictable with 8 millimeter or longer implant placed in residual bony height a lot less than 5 millimeters. So we can expect such kind of really high survival rate as long as we can place implant with more than 8 millimeters with the residual bony height of more than 4 millimeters. Giving a look to some literatures about transcranial approach, some papers didn't give a detail on the surgical method that they used, and traditional SOMS technique, which is not used anymore, was used in some papers, must be old papers. But nowadays, there are so many different methods to elevate the sinus floor, and we see many innovative surgical instruments for this method. So actually, nobody does sinus floor elevation the way SOMS did. So SOMS osteotomy technique is no longer available. Instruments for transcranial approach have been intensively investigated. People really love that approach. Each device has two components. One is for osteotomy and the other is atraumatic membrane lift. People modify the drills for the safety reason. You can find various type of drills. Piezoelectric device was also developed, and nowadays hydraulic pressure lift has been popular to prevent any accidental perforation. So this kind of hydraulic pressure is now kind of a game changer in terms of the transcranial approach method. So these modifications are mainly focusing on membrane integrity. So all that newly developed method is focusing on protecting the soft tissue. The traditional principle of internal lift was green stick fracture of the floor, but the current concept goes now to the controlled erosion of the floor using new instrument. Let me compare these three special drills available in the market. There must be more, but I want to talk about these three things. I will not tell you which is better and which is not. Everybody would have his or her own preference. The first one has a 4 inverse blade with conical tip. Bone chips produced during osteotomy moves up, and a bony lid produced at the top of the drill may help to reduce the risk of a perforation. I think the most durable than others and a little faster in osteotomy, I think, is my personal opinion. The second one is a traditional diamond point, which we are quite familiar with, but it can be easily worn out, and you may pay extra effort to maintain this in terms of the infection control. The last one has an S-shaped blade, packed bone chip at the top may protect the membrane. The upper third of this drill is a little thicker, so it may generate less side friction during osteotomy because it has a clubbed shape, and this may enable you to feel more tactile sense of the cortical flow when you do osteotomy. So the pressure that can feel from this kind of a transcranial approach using the third one is usually from the floor. But these characteristics are based on my personal preference, so uh, just take this uh, uh, as long as my personal preference is okay. Once the osteotomy done, the membrane should be elevated. Hydraulic pressure is recommended to lift without injury. Pushing the membrane with saline, you can feel some back pressure and regurgitation at your pushing finger. And the back pressure is getting weaker according to the graph on your right hand side. And the water comes into the osteotomy site with minimal resistance. So according to this well-written scientific paper, so mean peak pressure was around this number, but we really don't know how much pressure is exerted on our fingers. Anyhow, So this is a small video clip for hydro pressure lift. So you can see the piston of the saline uh, syringe is getting some regurgitation, but the amount of the saline in the syringe is decreasing a little bit, step by step. This is a typical case for transcranial approach. The patient has a certain amount of residual bony height, and the sinus floor is like flat. It is not slanted sinus floor. The cortical floor was eroded, and the Schneiderian membrane was exposed. You can see clearly the Schneiderian membrane at the uh, cortical floor, which is ground out here. The membrane integrity was checked with this depth gauge with a safe hand, and then hydraulic pressure can be applied. To grind out the cortical floor, tactile sense would be one of the important, and soft tissue palpation with a depth gauge would be important. So you can feel the soft tissue. So there must be some pressure giving back to your hands when you exerted some pressure with this kind of a probe-like instrument to the sinus membrane. So you can check the sinus membrane integrity with this instrument, and you can also push up that membrane with this probe-like instrument with a safe hand. And here the two dental implant were placed like this. And this is the pre-op and post-op panoramic radiograph. And on your right hand side, there is a X-ray after 2 years after the placement. So two dental implants were placed without graft material, and new sinus flow was confirmed after final restoration here. So this is a demarcation of the sinus floor, and the sinus floor just goes up like this. With all these innovative instruments, a perforation is still happening. So this is a clinical photograph of my patient. So you can clearly see the membrane, sinus membrane on your left-hand side, which is intact. But on your right-hand side, you can see a perforation, which is quite big. In this case, I didn't magnify this picture and gave a hydraulic pressure to lift up the membrane, but I was not able to get back pressure pushing the piston. So on your left-hand side, there is a really tiny, small perforation, but I was not able to recognize that small, tiny perforation at first. I realized the perforation after it got worse like this. Undetected minor perforations may end up with major trouble like this. So early detection would be great importance. So according to some paper, so detected population rate would reach around 3.8% to 26%. The mean rate was around 6% to 8%, which is really low. So how can we visualize a population during the transcranial approach? If you have a surgical microscope, then that would be really awesome, but not everybody can afford one. Instead, you can check what is happening with your DSLR camera like this. So on your right hand side, this is my camera. This is my camera. In case of a minor perforation, your implant can be protruded into the sinus cavity. But how much implant tip can be intruded into the sinus? We really don't know at this moment. But in this animal study, 2 millimeter of protrusion could be covered with soft tissue growth, but 4 millimeter protrusion may cause inflammation. It may be premature to say that 2 millimeter protrusion is okay with the result of this animal study, but the soft tissue healing potential may compensate a small protrusion of the implant. Sometimes your sinus slip does not work out the way you want it. You can still have a chance to place an implant. If these conditions can be met, you have to go for lateral window technique. So if you have uh, at least 8 millimeter implant and the diameter should be more than 4 millimeter and the protrusion is around 2 millimeter and the initial stability uh, which can be described like this with the value of ISQ that should be more than 65. We would need some undersized drilling for this purpose. And this means transcrestal approach is not made for people who cannot do lateral window technique. So anyhow, you should be able to uh, convert your transcrestal approach to the lateral window technique. So you have to be some kind of a surgical master in order to uh, carry out this a little bit more conservative surgery. So let's talk about the sloping floor. So moving on to the floor configuration. This is a typical sloping sinus floor. In this single molar missing area, the residual bony height from ranges from 4 to 10 millimeters. So we can say that this small span uh, have a really dramatic change of vertical height of residual bone. The inclination seems so steep while the medial-distal gap was really small. So this is the only single missing tooth gap, but the change of this residual bony height really dramatic. So basically, a sinus drill tip does not match with the shape of the floor in this case. So it would be really tricky to grind out the evenly grind out the cortical flow with this flat sinus drill. So in this case, you can also do lateral window technique. So we have some innovations like hydraulic pressure. So you still have a chance to carry out the transgressor approach. But in this case, lateral window would be a choice of mine. So I did lateral window technique in this case. So the surgical approach was quite simple and the sinus flow was done like this and the graft and a dental implant has been placed like this. And what can we do for a complex defect? Subantral bone deficiency often comes with horizontal defect. Lateral window technique is preferred to carry out horizontal ridge augmentation. In a complex defect, site development with enough bone to accommodate standard diameter implant is desirable in most of the cases. So if you would need some horizontal augmentation, which should be carried out with sinus floor elevation, then lateral window technique should be a choice of approach. So in this case, the width of the edentulous ridge was really narrow, so we needed some lateral ridge augmentation at the same time with the sinus floor elevation. So I did sinus floor elevation with lateral ridge augmentation at the same time. So horizontal and vertical gain was enough in this case to place two standard tissue level implant. So you can see here the lateral augmentation with some bovine bones and sinus floor elevation. So two tissue level implant has been placed. And this is a post-operative radiograph. And this is the 1.5 year after placement. So let me conclude my talk. So for 4 to 6 millimeter residual bony height cases, both methods may be available. So you can go for transcrestal and you can also go for a lateral window. From a patient point of view, lateral and transcrestal approaches are all acceptable. The most predictable result can be expected in residual bony height not less than 5 millimeter and dental implant should be 8 millimeter or longer. Current concept of internal sinus lift, transcrestal approach, changes from green stick fracture to green stick fracture of the floor to controlled erosion of the floor. You should carefully follow the manufacturer's instruction of each newly developed instrument not to misuse. So there are so many different types of instrument in the market. So you would need master some instruction and some specification of each instrument. In hydraulic pressure technique, back pressure, some kind of a regurgitation means membrane integrity, and following loss of the pressure means the detachment of the membrane from the floor. Early detection of a minor perforation matters. So in that case, you would need some kind of a magnification. So magnification of the osteotomy site would be necessary to check the membrane integrity. Without any magnification, you may not be able to find your tiny small perforation at the floor. Lateral window is highly indicated for sloping sinus floor and complex defect cases. So with the advancement of the recent newly developed transcrestal approach instrument, you can still have a chance for a transcrestal approach even in sloping sinus floor, but you should be able to do lateral window technique for the patient. Last but not least, such innovative instrument may not promote bone regeneration. It's all focusing on the membrane integrity. Please consider local and systemic condition of the patient for tissue regeneration. Thank you for your kind attention.